Thank you all for rejoining us. We will begin with the first session of the afternoon, the human papillomavirus vaccine, with an introduction by Dr. Peter Szilagyi, please.
Good afternoon, everybody. It's my pleasure to introduce this afternoon's HPV vaccine session. So the HPV vaccination policy issue being addressed by the work group is, should HPV vaccination be recommended for persons aged 27 through 45 years who were not previously vaccinated? So there's an expanded age indication for 9-valent HPV vaccine, as you know. The manufacturer filed a supplemental biologics license application in April 2018 to expand the age indication for 9-valent HPV vaccine from age 9 to 26 years to age 9 to 45 years. And this was approved by FDA in October of 2018. And as a reminder to you all, the 9-valent HPV vaccine is the only HPV vaccine currently available in the United States. So a recap of the past two ACIP sessions, we have had some significant policy discussions about HPV. In June of 2018, we had an overview and a history of the application for licensure in mid-adults. We presented data on HPV epidemiology, the natural history, and the burden of disease. And we presented clinical trial data that was included in the SBLA. In October of 2018, we reviewed the regulatory basis for the licensure, discussed several aspects of the U.S. vaccination program, including coverage and the impact on infection and disease. We reviewed HPV epidemiology and sexual behavior, post-licensure effectiveness studies, and global HPV vaccination and vaccine supply. We also reviewed GRADE in terms of efficacy, immunogenicity, safety, and then we reviewed preliminary health economic analyses and discussed some policy considerations. So that was October of 2018. Since then, the ACIP HPV vaccine work group has been very active, and topics reviewed all that relate to mid-adult vaccination since October 2018 include the following: the impact modeling and health economic analyses, HPV epidemiology and natural history, values and acceptability to stakeholders, and recommendation options for consideration. So in terms of modeling and health economic analyses for mid-adult HPV vaccination, 3 models were initially providing evidence for this policy question, and all are still going through CDC ACIP economic review, or were going through at the time of the October 2018 meeting, and actually are still. There are differences in the results across the models, and we presented preliminary data about this. And several workgroup calls have been devoted to these models and some of the differences. So today's HPV vaccine session will include the following. First, an overview and background presented by Dr. Lori Markowitz, who is our CDC lead. And then the impact and cost effectiveness of mid-adult HPV vaccination by Dr. Marc Brisson. An overview of health economic results from 4 modeling groups by Dr. Harold Chesson. Mid-adult HPV vaccination, patient values and acceptability by Dr. Nancy McClung. Program and vaccine provider surveys by Dr. Alyssa Miedis. And then Lori Markowitz is going to come back and review work group considerations for us. I would like to thank this very large and extremely active and productive HPV vaccine work group, the other ACIP members, Jose Romero and Kevin Alt, ex officio members, liaison representatives, consultants, a number of CDC contributors, and of course our CDC lead, Lori Markowitz, who will present next. Thank you.
Okay, good afternoon. The purpose of this presentation is to provide some background for the subsequent 2 modeling presentations and to describe some of the uncertainties regarding HPV epidemiology and natural history that impact considerations for mid-adult vaccination. Just as a reminder, the current recommendations for HPV vaccination in the United States are routine vaccination at age 11 or 12, catch-up vaccination for females through age 26, and for males through age 21. And certain populations can be are recommended to receive vaccine through age 26 as well, and males age 22 through 26 may be vaccinated. From work group discussions of mid-adult vaccination, I want to highlight that the work group affirms the importance of adult HPV vaccination and the primary focus of the immunization program on this age group. Regarding vaccination for mid-adults, vaccination is safe and it's also effective among mid-adults if they're exposed and susceptible to infection. However, the question being addressed is the additional health benefit and incremental cost effectiveness of extending the HPV vaccination program through age 45 or through another age between age 27 and 45 years. Preliminary results from 3 health economic models were presented to ACIP at the October 2018 meeting, and they're listed here. The groups that are doing the modeling, there were large differences in cost effectiveness for mid-adult vaccination across models. And so after October, CDC requested input from another modeling group, the Cancer Intervention and Surveillance Modeling Network, or CISNET. This is a modeling network funded by the U.S. National Cancer Institute. Modelers and ACIP CDC economic reviewers have been working to understand reasons for the differences across models. And as part of this effort, reviewers have asked all modelers to include a set of results using standardized health economic parameters to facilitate comparisons. And comparisons across models will be reviewed later by Dr. Chesson. Exploration of reasons for the large differences across the models focus not only on health economic parameters, but on others such as vaccination coverage, and the model structures have been reviewed. And also, HPV epidemiology and natural history parameters could have a large impact on the models. And so we reviewed some aspects that might be contributing to the differences in the model results. Now, most HPV attributable cancers are occurring in mid-adults or older persons, and the main question for the current policy discussions, and one of the issues that will impact the results from the modeling, is how much disease is due to incident infection that occurs in mid-adults. So I'm now going to review just selected issues regarding natural history that will impact considerations in mid-adults. Well, understanding the burden of disease due to incident infection in mid-adults requires consideration of many aspects of natural history, and we have discussed many of these in June and October. And as a brief summary, incidence is highest in the late teens and early 20s. Over 90% of infections clear or become undetectable. New infections do occur in mid-adults, and a new partner is the main risk factor. Epidemiology of HPV differs from males and females. And there's some uncertainty about immunity after clearance of natural infection, and this is thought to be generally low but higher for females than males. Progression to cancer occurs over years and decades, and among HPV types that are oncogenic, some types are more oncogenic than others, particularly HPV-16. And of course, less is known about the natural history of HPV and progression to cancer among males and females. This slide shows for the 6 HPV-associated cancers, the rates by age group and the median age of diagnosis from 2011 to 15. Among women on the left, the median age of diagnosis of cervical cancer was 49 years, and for the other cancers in the 60s. And for men, the median age of diagnosis for all cancers was in the late 50s or 60s. Again, the main question for our current policy discussion is how much of this disease is due to new infections that occur in mid-adults versus infection in younger age groups. This slide, which has been presented to ACIP at past meetings, shows results from one of the CISNET modeling groups attempting to answer part of this question and addresses what proportion of cervical cancers is caused by HPV infections acquired at different ages. The model estimate is that among women with cervical cancer, 50% acquired their causal infection by age 21 and 75% by age 31. The other modeling teams are also working to estimate the causal age at infection, and age at infection predicted by the models could account for some of the differences in cost effectiveness across models. Similar estimates of note have not been done for the other HPV-associated cancers. Now, the remainder of my talk will focus on HPV infection and natural history in females at the cervical site, as much more is known about this natural history. And I will review very briefly infection, time from infection to precancer, and from precancer to cervical cancer. This is a schematic showing the conceptual model of HPV infection leading to cervical cancer. And this graphic is not to scale, but shows approximately when these events occur. Again, infection is highest in the late teens and early 20s and then declines. Cervical precancers shown in green are detected during and after the peak of infection, but the timing of detection of the precancers depends on cervical cancer screening because these lesions are asymptomatic. Most infections clear or become undetectable with 1 to 2 years, and many precancers also clear, about 30 to 40%, and precancer can progress to cancer over years to decades. We have presented data to ACIP before from a variety of studies showing the decrease in prevalent and incident infection with older ages in females. Now, these data are from a study in Kaiser Permanente showing the proportion of women with a prevalent infection and enrollment into cervical cancer screening in red, and newly detected HPV infections at a follow-up among those who were negative at their first visit in gray. And you can see that both of these are significantly lower among the older ages. Seroprevalence data can also provide information on incidence of infection, although seroprevalence is an imperfect measure of cumulative infection for HPV, as not all individuals develop antibody after infection. These data from NHANES in the pre-vaccine era include any high-risk 9-valent HPV type seroprevalence in red and any high-risk 9-valent HPV type DNA prevalence in orange by age group. First, note that DNA prevalence is highest at age 20 to 24, as we've seen before, and lower in older age groups. Seroprevalence, shown in red, increased from 11% in 14 to 19-year-olds to 34% in 20 to 24-year-olds, and it's highest in the 30s. It did not change between the early and late 30s. And seroprevalence is lower in the older age groups as antibody from natural infection wanes and there's less new infection. Now, this is the same graph, but just showing seroprevalence to highlight that between the late teens and early 20s, there was a 23 percentage point increase in seroprevalence, and between the late 20s and 30s, there was an 8 percentage point increase. Now, these data are cross-sectional data, and age-specific findings could be due to cohort effects, but they do suggest new infection after the 20s, but less than between the teens and the 20s. Now, in this graph, we have displayed the age groups in smaller categories. And here you can see more clearly the rapid increase in seroprevalence in the late teens through the early 20s, from 8% in 14 to 16-year-olds to 30% at age 20 to 21. We can also use these data to estimate cumulative infection, and by age 20 to 21 years, an estimated 50% of females already had evidence of infection with at least one high-risk 9-valent HPV type, and this calculation was based on the assumption that 60% of females develop antibody after infection, as has been shown in prospective studies. This estimate, showing a large percentage of females infected by the early 20s, is consistent with the estimated age for causal infection from the model that I showed earlier in this presentation. Now, to understand the burden of disease due to incident infection in mid-adults, it would also be helpful to know time for progression of incident infection to precancer in cancer. Now, this might allow determination of age at which an infection occurred that caused that outcome. Time from infection to precancer has been estimated from the placebo arms of the HPV vaccine clinical trials and from cohort studies. Precancers are detected through screening, so duration of follow-up and intensity and screening methods in these studies will impact findings. Time from precancer to cancer is more difficult to study as it's unethical to follow women prospectively with untreated high-grade lesions, CIN3. However, it's likely to be decades based on the age at infection, the peak age at infection, and cancer diagnosis. It's also been looked at in models, and an estimate from a statistical model suggests a median of 23.5 years from precancer to screening detected invasive cancer, with only 1.6% progressing within 10 years. Now, coming back to the issue of time between infection and precancer detection. Shown here are data from studies that provide information on this. In the table are the age group in the study, the screening frequency, the duration of follow-up, and the median time from infection to the precancer detection, shown in the last column. There was intensive screening in these, ranging from every 4 months to every 6 months or a year, and the median time from incident infection to precancer detection was 1 to 2 years. Now, in the first study in this table, a simulation exercise was done to look at the impact of screening frequency on incidence, and some cervical abnormalities clear and would not be detected with less frequent screening. Cumulative incidence under the assumption of different screening intervals is shown, for example, after 48 months of follow-up. Every 4-month screening yielded cumulative incidence of low-grade cervical abnormalities of 29%, while every 24-month screening, the cumulative incidence was more than twofold lower at 11.7%. This simulation looked at low-grade lesions, and a smaller impact of screening frequency would be expected with higher-grade lesions, but the direction of the effect would be similar. I just reviewed time from incident infection to the precancer diagnosis in studies, and this can be short, but it could be impacted by duration of follow-up and screening. Age at CIN2 plus diagnosis depends on age at clinical screening initiation, frequency, and methods, and importantly, a CIN2 lesion can be present for years before it's detected because the time between CIN2 plus and cancer is long. And because of this, it's difficult to use age at CIN2 plus diagnosis to estimate when infection occurred with the kind of opportunistic screening we have in most of the United States. Now, when are these precancers detected in the United States? This slide shows age distribution of cervical precancers in 2008. These data are from CDC's 5-site population-based surveillance HPV impact. 2008 was before the impact of vaccination on precancers and before some of the changes in screening recommendations. And we used these data to make projections for the U.S. and estimated that the annual number of CIN2 plus cases in 2008 was 215,700, and the median age at diagnosis was 28 years. Now, to illustrate the challenges of estimating the age at infection from epi studies and surveillance data, I'm showing here data from 2 different sources. In the ALT trial, which was a screening trial conducted among U.S. women age 18 and older with every 6-month screening, the median age of CIN3 detection was 23 years. And in contrast, in the 5-site HPV impact surveillance project, in which there's opportunistic real-life screening, the median age at CIN3 detection is 30 years. Age at acquisition was likely similar, but the age at detection of precancer differed due to screening practices, and this, again, illustrates it's difficult to use age at precancer detection to estimate age at causal infection. So I did not provide an answer to the question about the amount of disease due to incident infection in mid-adults, but I highlighted several issues that are related to the challenges in determining this. One, there's rapid acquisition of HPV in the late teens and early 20s, and progression of incident infection to precancer can be within a few years. Over 90% of infections clear, and many of the precancers clear. Time from progression to cervical cancer is over 20 years. And age at precancer, cervical precancer detection depends on screening. And again, it's difficult to estimate age of causal infection from epidemiologic and surveillance data. And finally, less is known about the natural history at non-cervical sites and about progression from infection to cancer in males. So again, there are challenges in estimating the burden of disease due to incident infection in mid-adults from empiric data. And as I mentioned at the beginning, health economic models have estimated this burden. However, exact model-based estimates of the burden of disease due to incident infection in mid-adults is also challenging. And this is because they depend on a variety of assumptions that are included in the models, and this includes probability of infection, immunity after clearance, sexual behavior, partner mixing, and progression and regression of precancer lesions. And there'll be further information about this in the health economic analyses in the next two presentations. Now I want to shift gears to end my presentation and this introduction, and I want to mention very briefly two other issues as a way to introduce presentations later in this session. First, regarding mid-adult vaccination recommendations. Individual decision-making for HPV vaccination in mid-adults was one of the options being considered by the work group, and this was presented to ACIP in October 2018. Acceptability and values about individual decision-making in mid-adults have been explored for some key stakeholders, and these will be presented later in the session. I particularly want to thank AIM for conducting a rapid survey for us about this issue. Second, harmonization was in February 2018, before awareness of the application to FDA for the expanded age group, the ACIP work group was considering harmonization of the catch-up recommendations across genders. The work group has continued to focus on harmonization while considering mid-adult vaccination, and members of the work group support harmonization. And results from surveys on harmonization conducted prior to consideration of mid-adult vaccination will be presented also later in the session. I'd like to acknowledge several people who helped with this presentation, and of course all of the work group members. And now I'd like to introduce Dr. Brisson, who will present the HPV-ADVISE model, and he will be followed by Dr. Chesson, who will present a comparison across the modeling groups.
So good afternoon. I'd like to thank the ACIP for inviting me to present our work that we've been doing over the past year, looking at the cost effectiveness of extending HPV vaccination above age 26 years in the US. Before starting, I'd like to acknowledge my team at Laval University and collaborators at CDC and Imperial College. We have no conflicts of interest to declare. The work was funded by the CDC and also by other public institutions. So the study question that we were given was, from the healthcare sector perspective, what is the additional impact and cost effectiveness of extending the established HPV vaccine program in the US to females aged 27 to 45 years and from males 22 to 45 years? And the scientific objective was to evaluate the additional population level effectiveness and the incremental cost effectiveness of vaccinating females and males up to 45 years of age in the US against HPV versus the current recommendation. So in order to do that, we use our model, which is called HPV-ADVISE. HPV-ADVISE, which originally developed to help inform HPV vaccination policy decisions in Canada, but has since been used and adapted for policy decisions here in the United States, and more recently for global decisions with collaborations with the WHO. Our model is an individual-based transmission dynamic model, so it's important to note that it includes herd immunity effects from vaccination. Our model has 6 integrated components. There's a demographic component, sexual behavior and HPV transmission. We capture natural history of disease, vaccination, screening and treatment, and economics. Our population is open and stable, so we have individuals, women and men that age between 10 and 100 years of age, and we modeled 18 HPV genotypes individually, including the 9 types in the 9-valent vaccine. The diseases that we model are anogenital warts, cervical cancer, and cancers of the anus, oropharynx, penis, vagina, and vulva. A very important element when we're developing a model is not just the programming, but really to confront our model so that it reproduces actual epidemiological and behavioral data. So the fitting process is very, very important. And what we do is three steps. So the first step was for each of the parameters in our model, we found the minimum and maximum value in the literature. And then after, we sampled different combinations of these parameter values, and then identified the combinations of parameter values, so parameter sets, that were able to fit US data. And we make our model predictions using multiple parameter sets that fit this US data. The US data that we're fitting are sexual and screening behavior stratified by gender and age, HPV prevalence stratified by HPV type, gender, age, and sexual activity, incidence of anogenital warts, cervical lesions, cervical cancer, and other HPV-related cancers. In total, we fit 776 data points. So this is a figure of how we go about doing our model fit and then our predictions. So we had 200,000 different parameter sets. We ran them through the model and we found the 50 sets that fit the best the data. Once we have these parameter sets, we run them through the model again with vaccination to get effectiveness. So given that model fit is important, I just want to give you some examples of our fit. So here's an example of our model fit to sexual behavior. The outcome that we're showing as an example is the number of partners in the past 12 months in women, age 25 to 29 and 30 to 34. All of the fits will be pretty much look alike, where our blue boxes are the minimum and maximum value of our model predictions, and the red dots are the data. So here we're showing that we're fitting the number of partners in the past year for women quite well for these age groups, but we also fit the data quite well for other age groups and for men. We also show model fit to HPV prevalence. In women here, we have HPV 16-18 prevalence, and this is the model fit to HPV prevalence by age. We fit our data to the incidence of anogenital warts amongst females and males over age. We also fit our model to squamous cell carcinoma. This is the model fit to cervical cancer, but we also fit our data to the other HPV-associated cancers. So once we have our model, we have our 50 parameter sets, we wanted to validate the model to real-world data, so what is happening in the US post-vaccination. So here we show our model predictions compared to post-vaccination data in the US. So on the y-axis, you have percent change in HPV prevalence, and on the x-axis, you have time since start of vaccination. The blue lines represent the median result of our models. The dotted lines, the min-max, and the red dots represent the data. And you can see that we're fitting the data quite well. We were very happy with that. So once we have the model validated, and the model will continuously be validated. Once we have this, it's time to do model predictions. And to do the model predictions for this question, we really wanted to stick as much as possible to the experience in the US. So we're fitting the changes, we're reproducing the changes in vaccination policy in the US. So in 2007, we start off with 3 doses of a 4-valent vaccine amongst females 9 to 26-year-old. Then we switched to it in 2011 to gender-neutral vaccination, vaccinating men from 9 to 20 years of age. Then a switch in 2015 to the 9-valent vaccine with 3 doses. More recently, a switch in 2016 to 2-dose strategy in girls and boys less than 15 years of age. Now we're in 2019, and we have a new decision. Either to stick with the current recommendations or to extend HPV vaccination to mid-adults. In our model, we also reproduce the vaccine coverage, historical vaccine coverage from the US. For this, we use the data from NIST, with data that is among 13 to 17-year-olds. So we included in our model the observed uptake rates and changes in observed uptake rates from 2007 to 2016. We didn't have any data for 18-year-olds, so we assume that uptake rates are the same as 17-year-olds. And from 2017 onwards, we assume the uptake rates in the US are the same as in 2016. For uptake rates amongst women and men above the age of 18 years of age, we use uptake rates that were given to us by the CDC. This figure shows how our model reproduces the data for NIS-teen. So on the y-axis, you have the percent of individuals vaccinated at 17 years of age over time. The dots represent the data, and our solid line represents what our model is predicting or reproducing. And you can see that we produce the coverage extremely well. So now in terms of what are our mid-adult vaccination scenarios, well, we have 4 scenarios. The first scenario is a harmonization scenario where we're vaccinating men up to 26 years of age. And then after, we have 3 other scenarios, vaccinating females and males up to 30 years of age, females and males up to 40 and up to 45 years of age. And under these scenarios, these base case scenarios, we assume that the vaccination uptake is 2.6% per year amongst females and 1.9% per year amongst males. In terms of the economic analysis, it's from the healthcare sector perspective. We, in terms of costs, we include all direct medical costs, and our outcome is the cost per quality gained. We discount our costs and benefits at 3%, and our time horizon is 100 years. But 100 years starting from 2007, when HPV vaccination programs began in the US. In terms of the vaccination cost per dose, we use the costs that were given to us by the CDC. We also include economic costs in our model. We have a cost for genital warts diagnosis and treatment, cervical cancer screening and treatment, and the cost for treatment of HPV-associated cancers. We use costs that we found in the literature in our base case, but we also did a sensitivity analysis using the maximum cost that we found in the literature, but also used the standardized costs that were provided to us by CDC in order to enable the comparison of our results to other modeling results. So now the next slide is our first results slide, and it shows the impact of HPV vaccination with the current recommendation and HPV vaccination with the current recommendation plus mid-adult vaccination up to 45 years of age. The reduction in the HPV-related burden due to the current recommendation is presented by the blue line, and the red line is the predictions for mid-adult vaccination up to 45 years of age. So the way to see this slide is on the y-axis. You have percent change in incidence over time since the start of vaccination. Our model is predicting that over 100 years with the current recommendation, the US would prevent 13 million cases of SIN2-3, would prevent 32 million diagnosis of anogenital warts over 100 years, over 650,000 cancer cases, and just about 770 non-cervical HPV-associated cancers. Now, if we look at the extended vaccination scenario, we see that there's very little difference between the blue and the red line. So what our model is predicting is that there would be very small additional benefits of extending vaccination to females and males greater than 45. So you may wonder, why is mid-adult vaccination predicted to produce small additional reductions in burden compared to the current situation? Well, first of all, the first reason is the number of people vaccinated. So the number of additional people that are vaccinated by the extending vaccination to mid-adults is small compared to the enormous number of people that are vaccinated under the current program. That's the first reason. The second reason is herd effects. The current vaccination program is predicted to provide substantial herd effects amongst unvaccinated adults older than 25 years. So the incidence of infection and cervical cancer and other cancers among unvaccinated adults 26 to 45 years old will decline substantially due to herd effects. The third reason is the age of causal infection. In our model, it is predicted that a large proportion of cervical cancers are predicted to be caused by an HPV infection acquired before the age of 26 years. So this is sort of what we're showing here, where we're showing on this slide the cumulative proportion of the age of acquisition of HPV infection that causes cervical cancer. This is in a situation where you have no vaccination or screening. What our model predicts is that 50% of the cancers are caused by an infection that would occur before the age of 20. And this is very much in line with the results that Lori showed earlier from the Harvard group. We also found that about 80% of all of the cancers are due to infections that were acquired before the age of about 25, 26. So there's limited potential for additional gains by vaccinating mid-adults. So how does this translate into cost effectiveness? So this is our first cost effectiveness slide with our base case historical vaccination coverage. The first comparison to look at is the cost effectiveness of the current recommendation compared to no vaccination. Our model suggests that this is highly cost saving. So it is cost saving. So the current strategy is cost saving. Now we wanted to compare then different mid-adult vaccination scenarios to the current recommendations. The first scenario that we looked at was the harmonization schedule, where we vaccinate males and females up to 26 years of age. We weren't able to calculate a cost effectiveness ratio here, because with our population size in our model, we weren't able to estimate, to identify significant gains in this scenario. When we looked at the mid-adult vaccination up to 30 years of age, our median cost effectiveness ratio was $830,000. And when we looked at the scenario where we vaccinate men and women up to 45 years, our cost effectiveness ratio jumps up to 1.5 million. I also wanted to highlight that our results are quite variable. There's a lot of uncertainty around our estimates. So we're presenting here highlighted the 90% uncertainty intervals. And this is the 5th and 95th percentile of predictions generated by our 50 best fitting parameter sets. It could be the analog to a confidence interval. So they're quite wide. So we wanted to understand what were the drivers, why are our results so variable? And by looking at our results, we were able to identify that this is likely due to the variability in natural immunity parameters. And we found two sets of families of parameter sets. We found a set of parameters that had faster progression from infection to lesions and a lower natural immunity. So in these parameter sets, the average time from an infection to a lesion was about 2 years. In terms of lower natural immunity, these scenarios were predicting that the natural immunity following clearance in females was 35%. So the probability of developing natural immunity was less than 35%. The slower progressors, on the other hand, had an average time from infection to lesions of 30 months, and the probability of developing natural immunity after clearance was 35. So it did make a big difference. So if we look at, for example, our cost effectiveness of vaccinating females and males up to 30 years of age, our median result with the 50 parameter sets was $830,000. However, if we took only the family of parameter sets with faster progression, our cost effectiveness ratio was then 404,000. Whereas with the slower progressors, the cost effectiveness ratio was 2.4 million. So this, the variability in our predictions were mainly based on natural history assumptions. We also wanted to identify what are the other parameters that would have an impact on our results. Here we show our sensitivity analysis to vaccination parameters, and there were two parameters that came out. more than others. So here we're in a scenario where we're looking at the cost effectiveness of vaccinating men and women up to 30 years of age. The first parameter that had a big impact on our results was historical vaccination coverage. If we had lower historical vaccination coverage, our cost effectiveness ratios were much lower. So in fact, by just assuming a lower vaccine historical coverage, we went from $830,000 per quality gain to $336,000. The other parameter that had a big influence was vaccine efficacy. If we assumed low vaccine efficacy of the HPV vaccine, then the cost effectiveness was better. Why? Both of these scenarios, low historical vaccination coverage or low vaccine efficacy, makes it so that the current program has lower herd effects. So if you have less coverage, you have less herd effects. If you have a lower vaccine efficacy, you have less herd effects. If you have less herd effects, then you have less reduction in these men and women who are 26 years and older. And so the absolute potential reduction in these mid-adults will be bigger. So you'll have bigger potential for reductions in mid-adults if you have lower herd effects. I hope that was clear. We also looked at economic parameters and to see whether varying the economic parameters would have an impact on our predictions, and they did not significantly impact the model predictions. So we have strengths and limitations to our analysis. In terms of the strengths, HPV-ADVISE is calibrated to highly stratified US data. Our model is validated with post-vaccination US data. We have our predictions are consistent with age-specific post-vaccination HPV infection and anogenital wart diagnosis data from the US. And we also validated our model to post-vaccination data from Australia. Our predictions are made using 50 parameter sets, which captures the uncertainty in the natural history of HPV infection and related diseases and the variability in sexual behavior data. And this results in wide uncertainty intervals, reflecting that results are highly sensitive to the natural history assumptions and lack of data amongst mid-adults. And finally, we conducted sensitivity analysis on key parameters. We highlighted 4 limitations of examining mid-adult vaccination. First is that long-term herd effects of vaccinating younger age cohorts on mid-adult women and men remains uncertain. So if HPV-ADVISE, if our model overestimates herd effects of the current program, our results may overestimate the cost-effectiveness ratios of vaccinating mid-adult men and women. However, our model reproduces short-term post-vaccination herd effects. Second point is time to lesions and level of natural immunity after infection remains uncertain, and we've shown that model predictions are very sensitive to these natural history parameters. Third, the relative progression of a reinfection or a new infection in mid-adults versus younger adults is unknown. So HPV-ADVISE assumes that progression is independent of age. However, it has been suggested that a proportion of redetections is due to deposition with a recent sex partner, and that new infections later in life have a smaller risk of progressing to cervical cancer. And if this is the case, then mid-adult vaccination would produce lower benefits and higher cost-effectiveness ratios. And finally, screening recommendations are constantly changing in the US. If changes to screening results in more effective cervical cancer prevention, mid-adult vaccination would produce lower benefits and higher cost-effectiveness ratios. So in summary, current HPV vaccination programs are predicted to reduce the burden of HPV-related diseases substantially and is likely cost-saving versus no vaccination. Extending vaccination to 45-year-old females and males is predicted to produce small additional reductions in HPV burden of disease and results in cost-effectiveness ratios greater than 360,000 per quality gain in 95% of model simulations under our base case assumptions, and our median is 1.5 million. And finally, the cost effectiveness of mid-adult vaccination is highly sensitive to natural history assumptions and also to historical vaccination coverage. So thank you very much.
Good afternoon. So what I'll do now is give an overview of all the modeling results, including those just presented by Dr. Brisson. So just to let you know, the ACIP Health Economics Review is still ongoing for 4 of the 5 models that I'll be presenting today. The model just presented is the only one that has completed the review process. So the results from the other models that I present should be considered preliminary. The required conflict of interest statements are shown on this slide. So at the October meeting, we provided a review of the 3 models available to us at the time, and we showed that there were notable differences in the cost effectiveness estimates across the models. So since then, we've made some progress in examining these issues. The HPV-ADVISE estimates have been finalized. The simplified model has been adjusted to better approximate scenarios where there is reinfection, and the Merck model has been changed. It's been recalibrated to fit pre-vaccine era HPV prevalence data, and it now uses NIS teen data for historical vaccination coverage assumptions as in the other models. Also, as Dr. Markowitz mentioned, we now have results from 2 CISNET models now available, and we have a better understanding of some of the reasons for the differences across the models. So these are the 5 models available to us now, the 3 models that I presented in October, and also 2 CISNET models, one from Harvard and one from Australia. All 5 of these models are dynamic, that is, they include herd effects. They also include a wide range of health outcomes that can be prevented through vaccination, such as cervical cancer and other HPV-associated cancers and genital warts. All of the models apply recently published estimates of the medical costs for HPV-associated cancers. The models all exclude productivity costs, and they all examine a relatively long time horizon to capture all of the benefits of HPV vaccination. So now I'll show a few slides of the selected model attributes. 3 of the 5 models are individual based, and as you might think, that means the models keep track of individuals in the population. 2 of the models are compartmental. They keep track of groups of people in the population. All of the models except the simplified model include historical vaccination coverage. And in terms of model calibration, as Dr. Brisson just showed, his model uses the 50 best fitting parameter sets, whereas these other models shown here use a single best fitting parameter set for the analysis. All of the models except the simplified model assume that the vaccine will protect against reinfection for those who are vaccinated after clearance. As far as cervical cancer screening assumptions go, HPV-ADVISE and the Merck model approximate real-world cervical cancer screening. The CISNET models in the base case assume perfect compliance to cervical cancer screening guidelines, but they also, in sensitivity analyses, examine the impact of applying real-world screening scenarios. The vaccine uptake among mid-adults is shown here. It's similar for all the models and uses the numbers that Dr. Brisson just presented. The only difference really is that Merck allows for the possibility of incomplete vaccination series, so some mid-adults might get 1 dose or 2 doses rather than all 3 doses. And as in the previous presentation, the models are calibrated to fit the data, and one of the parameter values that is fit during the calibration process has to deal with natural immunity. And I won't go into the details now, but just to show how in all the models but the simplified model, there are assumptions regarding natural immunity. So now I'll move on to some of the results across the models. Before showing the cost effectiveness results, I'll just show an EPI result from 3 of the models. This shows what the model suggests about the median age of first acquisition with at least one of the high-risk non-valent types. And in the HPV-ADVISE and simplified model, it's closer to age 20 or 21, and in the Merck model, the median age is around 25 or 26. And as in Dr. Markowitz's presentation, from the NHANES seroprevalence data, we estimate if you assume 60% of females develop antibody after infection, that this median age is somewhere about 20 or 21 years. As far as the cost effectiveness of the current HPV vaccination strategy, the HPV-ADVISE model, as you just saw, is estimated to be cost saving. This is a very consistent result with the other models, which find a very low cost per quality for the current vaccine program versus no vaccination. So before showing the cost effectiveness results for mid-adult vaccination, I just want to say that I'll be presenting two main measures. The first is looking at the cost effectiveness of adding mid-adult vaccination through age 30 years versus our current program. And I'll also be showing estimates for extending mid-adult vaccination to age 45 years versus the current program. And though I'm not presenting it today, the modelers have examined a wide range of other strategies such as vaccination to age 35 or 40, and they've looked at incremental cost effectiveness ratios, like what is the cost effectiveness of going from mid-adults age 35 to age 40 and so on. But I will just show the simpler measures shown at the top of the slide in this presentation. So this table shows the base case results from the models of mid-adult vaccination through age 30 years. So the median from the 50 parameter sets in the HPV-ADVISE model was about 830,000. The estimates in the other models range from about 100,000 in the Merck model to over 600,000 in the CISNET Harvard model. So the next table will be similar, but we'll look at vaccination through age 45 years. Again, the median in the HPV model was about 1.5 million. These estimates range from about 150,000 in the Merck model to about 400,000 in the simplified and CISNET Harvard models. I want to draw your attention to a distinctive feature of the CISNET results. What this table does is summarize the results from the previous two slides. It looks at the cost effectiveness of extending the current program to either 30 or 45 years. And what's interesting in the CISNET results is that the cost per quality is lower for age 45 than it is for age 30. And this was a bit of an unexpected result because typically the cost per quality gained by HPV vaccination is estimated to go up when we increase the age at vaccination. We think the main reason for this are the herd effects mentioned in the previous presentation. Because we're vaccinating younger people, we're having herd effects among unvaccinated mid-adults. So if you think about the herd effects as a wave moving from the young people to the mid-adults, that wave will hit the younger mid-adults before it hits the older mid-adults. So there's more room for the vaccine to have an effect on the older mid-adults up to age 45 rather than the younger mid-adults under age 30. So what can account for the differences across these models? We've looked at several factors, including health economic parameters. The issues such as the medical treatment cost assumptions and quality of life assumptions could have an impact. And the ACIP reviewers asked the modelers to include a set of results when using a standardized list of these parameters. We've also know that historical and future vaccination coverage assumptions can affect these estimates, and also assumptions and model structure regarding sexual behavior and HPV transmission, natural history of infection, and cervical cancer screening characteristics. So can the differences in results be explained by differences in the health economic assumptions? And the answer to that, we don't quite know yet. These analyses are not yet complete, but we certainly will have them very soon and definitely before the next meeting. So do historical vaccination coverage assumptions matter? All of the models include historical vaccination coverage except the simplified model. The simplified model, instead of looking at should we add mid-adult vaccination to an ongoing program that's been in existence for over a decade, what the simplified model does is say, okay, if we were to start HPV vaccination today, what would be the cost effectiveness of including mid-adult vaccination in the program? And this does matter when we assume lower historical coverage or no historical coverage. The cost per quality gained by mid-adult vaccination is much lower. And the reason is with lower historical vaccination coverage, there's less herd effects of the current vaccination program on mid-adults. So there's more potential benefits of mid-adult vaccination. So what we've shown in this slide, in the results shown in red, is the HPV-ADVISE and the Merck model got rid of the historic vaccination program to make them compatible with the simplified model assumptions. And in doing so, the simplified model result and the HPV-ADVISE result are much closer together than they were before. So what do we learn by exploring multiple parameter sets? As Dr. Brisson showed there, the model they uses the 50 best fitting parameter sets, and the Merck and CISNET models use the single best fitting parameter set. And the answer to this is that using the multiple parameter sets helps us to understand how sensitive the results are to key assumptions regarding natural history of infection and transmission dynamics and so forth. And as in Dr. Marquis's presentation, these assumptions are subject to considerable uncertainty. And just as a recap of the results just shown, across these 50 parameter sets, the cost per quality gained by mid-adult vaccination through age 45 range from the median of about 1.5 billion and to a low of about 360,000 to undefined. What is the effect of assuming perfect screening compliance? As I mentioned, the CISNET models assume perfect cervical cancer screening in their base case, and the HPV-ADVISE and Merck models simulate real-world screening. And the answer is that the CISNET estimates of the cost per quality gained by mid-adult vaccination are much lower when assuming real-world screening rather than perfect screening. And that's because there's more potential benefit in these scenarios for the vaccine to prevent cervical cancer. So what this slide shows for the CISNET models in red is their estimates when assuming real-world screening rather than their base case assumption of perfect screening. So the summary and next steps. What we wanted to do with this table was just to summarize what the studies show us about the general range of the cost per quality estimates for mid-adult vaccination. And what it does is it asks the question, is the cost per quality gained by mid-adult vaccination through age 30 years less than these following values? So for example, the first row of results showed if you were to ask the question, is the cost per quality gained less than $100,000, the answer would be no in all of these models. If you ask the question, is the cost per quality gained less than $150,000, the answer would be yes in the Merck model, and it would be yes in the lower bound of the HPV-ADVISE model, but it would be no in the other models. And as you can see, if you go all the way to the highest value we have here of 500,000, there's two of the models that suggest that the cost per quality gained by mid-adult vaccination up to 30 years costs more than $500,000 per quality. This is the same table, except for we're looking at through age 45 years. And what this table shows is that if you look around the $300,000 mark, at that point there's still agreement across most of the models that the cost per quality gained by mid-adult vaccination through age 45 years is not less than $300,000. So to summarize the cost effectiveness estimates from the models, we know that the current program has a very favorable cost effectiveness profile. The program is likely cost saving, or at least a very low cost per quality adjusted life year gained. All models find that mid-adult vaccination is relatively less cost effective than the current program. However, because of the uncertainties in the natural history of HPV and transmission dynamics and other factors, we can't provide a single precise estimate of the cost effectiveness of mid-adult vaccination. We can only show the ranges across the models. And again, these ranges, if we look at mid-adult vaccination through age 30 years, the cost per quality gained exceeds $200,000 in 3 of the 5 available models, and it exceeds $300,000 in 3 of the 4 models that take into account historical vaccination coverage, and it exceeds $800,000 in the median of the HPV-ADVISE model. Similarly, if we look at mid-adult vaccination through age 45 years, the cost per quality exceeds $300,000 in 4 of the 5 available models. It exceeds $400,000 in 3 of these models, and in the HPV-ADVISE median result, the cost per quality exceeded $1.4 million. So the next steps, we want to complete the ACIP review that's now ongoing for 4 of the 5 models. We will continue collaboration with the modelers to understand the important differences in the model structures and assumptions that drive the results. We hope soon to have the completion of the standardized health economics assumption scenario and to provide more detail to the HPV work group, and of course to prepare for the June meeting and address any issues that you raised today. So now I'll turn it back over to the chair regarding comments from other modeling groups in attendance.
I'd like to thank everybody for some very nice presentations, and then I'd like to invite Dr. El Basha from Merck to comment about their HPV modeling if they'd like.
Good afternoon. I am Alamin Al-Basha from Merck. I have led the development of the Merck HPV model over the last 16 years or so. Thanks for the opportunity to share Merck's perspective on the public health impact and the cost effectiveness of expanding vaccination to age 45-year-old. According to analysis from the Merck model, expanding vaccination avoids significant disease and deaths. Approximately 26,400 cancer cases, 8,800 cancer deaths, and 1.6 cases of anogenital warts and cervical lesions at an incremental cost-effectiveness ratio, ICER, of less than $150,000 per QALY. Several other policy options for expanding the program were not highlighted but have lower ICERs. These include limiting the duration of the program to only 10 years, expanding only to women, or expanding the program to only age 35 for both men and women. The findings that the results from all these models did not align requires further investigation, as mentioned by Dr. Chesson. As you saw that in the younger cohorts in the current recommendation, these models have aligned. It is unusual for models to have wide variation in results like this. We think it is important that all modeling groups to work together to fully understand what might be driving the results and the differences in the results. This would include sharing equations, inputs, and other technical details of their models. We would welcome further review by the CDC team, any advice from the ACIP work group and the ACIP, and any opportunity to work with other modeling groups, including participation in a face-to-face meeting. This would greatly help decision makers to accurately assess the public health impact and the true economic value of expanding HPV vaccination to 45 years old. Thank you.
Thank you. So I will open it up to questions from the voting members. Dr. Teller.
Thank you. And there's an awful lot of work that went into all that modeling. However, the first thing that went through my mind is this would be a permissive recommendation for someone who's newly at risk or has a changed risk. And none of these models evaluated by risk. Is that something that's feasible, too difficult? I mean, I can't imagine a 35-year-old in a committed relationship all of a sudden is at risk, but a 35-year-old who's divorced and out exploring would be at a completely different risk and would have a different quality. Oh, and just for the record, 30 is not middle-aged.
Yeah. Well, we should have defined at the beginning that we were calling mid-adult, what our definition was. We did have that as a footnote on the slides. I did mention at the beginning that one of the work group is considering the option of individual decision making, which is consistent with what you're talking about. And so we have been spending a lot of time looking at the modeling, and we do hope to be able to address this issue of who would benefit. Is it the low risk people who are now just entering, re-entering, higher sexual activity, or is it high risk people who are continuing high risk sexual activity? I don't know if Dr. Brisson, do you want to say anything, or is that sum it up? Yeah, I mean, we haven't examined that. It's another whole project for the modelers, but I think that's a very good question.
Eche.
I'm just wondering that herd effect seems to be an important factor in all the modeling that we have just been shown. So if we look back, we have a 10-year history of vaccine uptake and what it could be. So if you look out 10 years from now, do we think vaccine uptake will increase or decrease or stay the same? Because it seems to be something that affects the herd immunity and which kind of affects all the model.
Even if we have if the current uptake remains what it is, we will, eventually be getting higher coverage as vaccinated people age into the older age group. So the models do take that into account, and of course, with higher coverage, you'll get higher herd immunity. But the models right now, and I don't know if Dr. Chestnut or Dr. Brisson want to address this, they're assuming current coverage as we're seeing in NIS teen, and then it's kind of leveling off at a certain level.
Yeah, so our assumptions is that at some point we reach an equilibrium in vaccination coverage of about just under 80%. And with these sorts of vaccine coverage, we'd expect substantial herd effects. And if you look at data from other countries that have reached very high coverage or coverage that is around 80%, you see, and that reach that quite rapidly, you see these important herd effects in these older age groups. And so we're seeing it with real world data that there are herd effects occurring in men that are not vaccinated, but also older women. There's a good literature on that.
Just before you leave, one of the things that was interesting about it is some of the options that was brought up, we didn't really hear it, is where you think about making this recommendation for 10 years and stopping. So it becomes very important. If you're saying you are trying to catch up for the next 10 years, you want to do this mid-age vaccination and then stop. Yeah. It becomes very important and an option that should be considered, because what you're basically trying to do is a catch-up, so that by the time after 10 years, a lot of the people who have received vaccination would have aged, so that the gain may not be continuous. Yeah. So that's why I was asking about the uptake and why the 10 years.
So we're talking about this wave of herd effects. And it's true, when we actually did some additional analysis, and what Dr. El-Basha was saying about looking at maybe a catch-up of mid-adults, whether that would be more cost-effective, and it would be more cost-effective, because the main gains that we're predicting with the model, and I'm sure the others, are in the first cohorts that are vaccinated before all of the herd effects kick in. So I think it's a very good idea to look at the duration, whether it would be worthwhile and cost effective, and what would be the benefits of a short-term mid-adult vaccination strategy. And the other suggestion about vaccinating only females, we looked at that. We didn't present it, but we looked at that, and that also is more cost effective just to vaccinate mid-adult women.
So is that something that we should we should have access to a little bit before we have to make some decisions to look at those options? I know it wasn't presented today, but I thought the recommendation that he made, that all the modeling get together kind of saying can provide us a little more information. If that information will include what it will look like if we have a 10-year ad hoc or catch-up.
So I think that it would be interesting to know from you if you think that looking at alternative strategies such as a 10-year catch-up is worth it. I think that it would be interesting to look at that, to look at the outcomes in terms of cancers and HPV-related burden prevented and the cost effectiveness, to see how much better it looks. In terms of the comparative modeling, we, with WHO, I was involved in a paper that we're writing on how to do comparative modeling. And it's not to necessarily get into a room and to start, debating on, who's right and who's wrong. There's a systematic approach that can be done to that is better than everyone sitting in a room. Sitting in a room is not going to change things. A systematic approach towards comparison, comparing the models is a better way, according to, at least that's what I think.
I'll give the final word to Dr. Lee.
Just a comment. It's a really interesting strategy that you just suggested. I think it's actually a question for us as ACIP members, because what you're suggesting is sort of a precision public health approach, which is optimize the health benefit for the population, but target those recommendations accordingly. The challenge is with implementation and de-implementation of programs, and that is part of our evidence to recommendation framework. How easy is it to set up a program in the older adult population, and then how easy is it to take down? And I think that we're finding the same challenges in the pneumococcal recommendation.
I'm sorry, I know there's still questions, but for the sake of time, we have to move forward. We can carry this on later. Great. So the next three speakers will have questions afterwards. Right now, Dr. McClung will talk about mid-adult HPV vaccination and patient values and acceptability.
Patient values and acceptability are part of the evidence to recommendation framework. The objective of this presentation is to review what is known about patient values and acceptability for HPV vaccine in mid-adults 27 to 45 years that have been reported in women, men, and in men who have sex with men or MSM. We conducted a literature search using PubMed for HPV vaccine acceptability, and we included U.S. studies with information reported in mid-adult women or men, and if greater than 50% of the sample was aged 26 years or more. After reviewing 336 results, 10 papers were selected for inclusion, 6 in women, 2 in men, and 2 in MSM. First, I'll review values and acceptability in mid-adult women, and the studies are ordered by year that the data was collected. The most recent, from 2014, assessed wanting to receive the HPV vaccine if a provider had it available and recommended it. 50% of women reported definitely or probably wanting it. The next study assessed, on a scale of 0 to 100, willingness to be vaccinated if the vaccine was free. The mean score was 64. The next study assessed relevance of the HPV vaccine, and 67% of respondents reported that the HPV vaccine was relevant to them, and of these, 71% reported likely to get the vaccine if available. Another study found 66% of respondents were likely to get the vaccine if it was free. And the last two studies assessed values and acceptability prior to routine recommendation in the US. In the first, 85% reported that if an HPV vaccine was approved to prevent cervical cancer, they would want to get vaccinated. And the second found 77% would accept the HPV vaccine if it worked at any age. Common reasons that mid-adult women report not valuing or intending to receive the HPV vaccine include being married, being in a monogamous relationship, low risk for HPV infection, lack of sexual activity, or unknown adverse effects. Next, I'll review values and acceptability in mid-adult men. Of note, all of the studies in mid-adult men took place prior to routine vaccination in men. The most recent study included men in a longitudinal HPV study and reported likeliness to get the vaccine if safe and effective for males, and it's reported by race and ethnicity. 74 to 94% of men reported likely or very likely to be vaccinated. The next study assessed willingness to get the vaccine if it was approved for males, and 37% reported yes. The next study among MSM assessed willingness to receive the vaccine. 86% reported yes. The next study was also among MSM and also assessed willingness to receive the vaccine if approved for males, and 74% reported yes. Common reasons mid-adult men report not valuing or intending to receive the HPV vaccine include for heterosexual men being married or living with a partner, or having less than 5 lifetime sex partners, and for gay or bisexual men having less than 5 lifetime sex partners. There are a few limitations to the studies in this review. First, it's important to note that all studies were conducted prior to licensure through age 45 years. Thus, the values and acceptability reported in these studies do not directly relate to expanded age licensure, but are based on a hypothetical situation. In women, the most recent data was collected more than 5 years ago, and in men, all of the studies occurred before routine HPV vaccine recommendation was made for men. In conclusion, overall value and acceptability of HPV vaccination was moderate. Valuing or intending to receive the HPV vaccine was reported by at least 50% of the sample in all studies, but one. Willingness to receive the vaccine was high in both studies among MSM. However, HPV vaccination was not valued by all respondents, and the most common reason the vaccine was not valued was low perceived risk for HPV, being married in a monogamous relationship, or having few sex partners. I'd like to acknowledge my colleagues who will present the last two topics on HPV today. Thank you.
Good afternoon. I'll be presenting the results of program and vaccine provider surveys regarding mid-adult HPV vaccination. The evidence to recommendations framework includes consideration of acceptability of mid-adult HPV vaccination to key stakeholders, and in addition to patients discussed in the previous presentation by Dr. McClung, key stakeholders also include immunization programs and vaccine providers such as physicians. And this presentation summarizes data from 4 different surveys on 2 issues related to adult HPV vaccination: harmonization of upper age catch-up recommendations across genders, including surveys of programs and primary care physicians, and individual decision-making, including surveys of programs related to mid-adult HPV vaccination and primary care physicians on Category B recommendations. The first survey is a harmonization survey of immunization programs conducted in January and February 2018 by the Association of Immunization Managers. Among 64 immunization programs, response rate was 80%. About 3/4 of these programs purchased adult HPV vaccine through the CDC contract and also provided adult HPV vaccine to any health department clinic. And this survey found that 96% of programs were aware that catch-up recommendations differ between males and females, and 59% stated that the current recommendations cause challenges or confusion. Almost all, 98% of programs, were in favor of harmonizing the recommended age for catch-up vaccination to include everyone through age 26 years. Reasons why 50 of 51 programs were in favor of harmonization were, from top to bottom, easier to implement, easier to explain to patients, would simplify health department recommendations and guidelines, easier to explain to providers, facilitate reaching high-risk populations, create equity between genders, and reduce burden on healthcare providers. A second harmonization survey of primary care physicians was conducted in January and February 2018 by the University of Colorado. Among 1,383 physicians, including about equal numbers of pediatricians, family physicians, and internal medicine physicians, response rate was 59%. Here, only about 58% said yes, they were aware of the difference in catch-up recommendations for males and females. And about a quarter, 27%, said the current recommendations have caused challenges or confusion in their practices. Again, most, 93%, were in favor of harmonization across genders. Reasons why 713 physicians favored harmonizations were: simplify the vaccination schedule, easier to implement, easier to explain to patients, facilitate reaching high-risk populations, reduce burden on healthcare providers, and create equity between genders. Reasons why 53 physicians did not favor harmonization were: I don't have a problem with the current recommendation. Vaccination is less cost-effective in older age groups, and I don't think HPV vaccine should be administered to all males in this age group. Now we change topics to individual decision-making for mid-adult HPV vaccination. The third survey was also of immunization programs and conducted again by the Association of Immunization Managers in January and February 2019. Of 64 immunization programs, response rate was 64%. The first question was, if there is a recommendation for individual decision-making for vaccination of mid-adults, how challenging would it be for your immunization program to communicate the recommendation to vaccine providers in your jurisdiction? In red, 5 programs, or 11%, responded that it would be very challenging. In yellow, 22 programs, or 49%, said somewhat challenging. And in green, 16 programs, or 36%, said not challenging. The second question was, if there's a recommendation for individual decision-making for vaccination of mid-adults, in your opinion and or experience, how easy would it be for vaccine providers to determine patients in this age group who might benefit from vaccination? In green, 5 programs, or 11%, responded that it would be easy. In yellow, 14 programs, or 31%, said somewhat easy. And in red, 19 programs, or 42%, said not easy. And the third question was, do you anticipate any challenges to implementing such a recommendation? In red, 31 programs, or 69%, said yes. And in green, 14 programs, or 31%, said no. Some of the stated reasons why programs said individual decision-making could be implemented are FDA has already announced licensure of HPV vaccine through age 45 years. Some immunization programs, but not all, already have effective mechanisms in place to communicate new recommendations to adult immunization providers in their jurisdiction. It's easy to identify patients in the mid-adult age range using EHRs or electronic health records. And identifying patients who are most likely to benefit might be easier for certain provider types. For example, clinicians who are already regularly vaccinating adults and assessing sexual histories. Some of the stated reasons why programs said individual decision-making could be challenging were the primary focus of the HPV vaccine program is to vaccinate children and adolescents. Expanding the age range in any way could distract from this main goal. HPV vaccine messaging should remain focused on cancer and disease prevention, not sexual transmission. Individual decision-making could undermine communication of prevention messages for adolescents by reinforcing transmission messages to adults. IIS, or immunization information systems, are unable to forecast for individual decision-making and would have to prompt all or none in the mid-adult age group to have a conversation. Not all vaccine providers assess sexual history, and not all patients disclose. So this might be too complex, confusing, or time-consuming for vaccine providers. And lastly, there's little funding for adult vaccine programs, and 317 funds are already spread thin. Fourth, although a provider survey on individual decision-making has not been conducted for HPV vaccination, the work group did review results of a 2016 survey conducted about what was then called Category B recommendations for Men B, and again by the University of Colorado. Among 916 primary care physicians, response rate was 72%, including 374 pediatricians and 286 family physicians. Overall, 89% said they needed additional guidance on how to tell patients what a Category B recommendation is. 69% felt that vaccines with a Category B recommendation require more discussion with patients than Category A or routine recommendations. And 45% did not know that private insurance companies routinely cover Category B vaccination recommendations. And the work group noted that current terminology, using individual decision-making instead of Category B, might reduce some of this confusion and acknowledges the importance of clear guidance with this type of recommendation. In summary, for our first topic, harmonization of upper age for catch-up recommendation across genders would likely be acceptable to key stakeholders, including 98% of immunization programs and 93% of primary care physicians. And as a reminder, these surveys were conducted before vaccine was licensed above age 26, but interest in harmonization across genders likely still applies. And for the second topic, Individual decision making for persons older than the routine catch-up age group through age 45 might be acceptable to key stakeholders. The majority of immunization programs anticipated challenges communicating such a recommendation. Almost half thought it would be easy or somewhat easy for providers to determine who might benefit from vaccination, and about a third anticipated no challenges with implementation. And these data will be incorporated into the evidence to recommendations framework on acceptability of mid-adult HPV vaccination to key stakeholders. Thank you to all the work group members.
To end this session, I want to mention briefly the work group considerations for recommendations for mid-adult HPV vaccination. Again, these are our current recommendations for HPV vaccination in the United States. You saw these earlier: routine vaccination 11 or 12, catch-up for females through age 26 and males through age 21, and males 22 through 26 may be vaccinated. The work group is still reviewing results from the health economic analyses, which you heard earlier in this session, as well as other data related to this policy question. But I do want to let you know our current discussions, because several policy options have been discussed. And what I will do now is summarize these discussions for you and the options in terms of a majority and a minority opinion. So the majority opinion, which is favored by a large majority of the workgroup members, is for a harmonized upper age for catch-up for males and females. This could be the current age or another age, for example, 26 or 30, and younger ages for harmonization were discussed as well. And for those older than the catch-up age, individual decision-making through age 45 years. The minority opinion was very similar in terms of catch-up. That would be harmonization of the upper age for catch-up for males and females. This would be, again, the current age or another age, 26 or 30, or possibly a younger age or an older age. But there would be no recommendation for vaccination for those older than the harmonized catch-up age. And I want to say something about this minority opinion. Concerns among workgroup members favoring no recommendation above a harmonized catch-up age. Possible reasons for this were that there were few benefits for vaccination in the older age group. It would be a diversion of focus from the adolescent vaccination program. A few members thought there were potential harms to the vaccination program due to temporally associated adverse events in this age group. And we also did discuss the current global HPV vaccine supply situation, which was discussed with ACIP in October, and this was important for a few workgroup members. Of note, no workgroup members were in favor of a catch-up recommendation through age 45 years. Now, if individual decision-making is recommended in some age groups, the work group did understand that there would be challenging about what guidance to provide, how to communicate who might benefit, and how to communicate the lower effectiveness in this age group. And so these are all things that would have to be worked out, and the work group acknowledges that. So the next steps for the HPV vaccines work group is to continue to review results from the health economic modeling and other related data, to complete the evidence to recommendations framework, certainly to incorporate any feedback we get from ACIP members today, and hopefully to prepare for a vote in June 2019. Again, the entire HPV vaccines work group has really done a lot of work in the last few months as we've been preparing for this ACIP meeting. I want to thank all of the members.
Very good. We'll open it up to comments and questions again. Dr. Hunter, you had a comment or question at the last group.
The ability to implement a cohort-based, age-based recommendation that would be not individually decision-making, but a routine, could be conceived of as a cohort-based by year of birth, similar to how hepatitis C testing is done, and that you test everybody for this hepatitis C from age 1945 through 1965. If you just chose, I'm not suggesting that this should be done, I'm just saying it could be done. If you chose that you wanted to do catch-up through age 35 of a cohort that's right now, you would just take those years of birth and use that on top of a general individual decision-making recommendation that would persist ongoing. And then once you aged out of that cohort of people, then that previous age-based recommendation would just disappear. I'm just saying that could happen. I'm not sure that's the right thing to do. But I do think that it makes sense to do a little bit more cost-effectiveness analysis to see if that makes sense to do even.
Eche, go ahead.
So there's something I wanted to understand about the individual. Isn't that automatic that, it's individual, even up till now? If you wanted to get a vaccine, you pay for it and you get it. So I want to understand what is different. We're talking about making the individual recommendation and how it would differ from what we have now.
Do you want to answer that?
Sure. So if you make an individual, if ACIP recommends a vaccine for individual clinical decision making, that means that the vaccine goes on the schedule for that age group with a particular color line, which I'm forgetting right now. It's a color, though. We talked about it a lot one day. So it has a different color than for routine, and that actually both, cues providers to think about offering it or to consider it for their patients, as well as provides coverage and through the ACA. Melinda, is there anything else to add?
No, so really the difference is going to be that the insurance will have more likelihood of paying for it if it has this color change, because the evidence is what the evidence is, whether it's effective, whether it's less effective. In terms of if you feel at risk and it's a vaccine that is already approved by the FDA, you can get it. The difference, and the doctor can give it to you if it's already FDA approved. The difference in those recommendations is about payment. Or is there something else I'm missing?
I think that payment is one of the key differences. I also do think that it is, providers use the schedule and programs consider it as part of their decision-making when it's included on the schedule versus not being included on the schedule. Peter, do you want to?
I just want to emphasize that. I think if ACIP makes an individual clinical decision-making, ACIP is recommending that clinicians go through the process of making individual decision-making, as opposed to with no recommendation, that means ACIP is silent on it. So with individual decision-making, there would be guidance that follows. So it feels like a different level of thought process. And the insurance is important, and that was discussed at the work group. If there was no recommendation, our understanding is that insurance won't cover it.
Dr. Hall.
I think also in women's health, there's a fair number of examples: breast cancer screening in young women, contraception, screening for aneuploidy during pregnancy, where there's probably multiple ways to talk about things and some ambiguity in the data as well. So, I think it implies that as well.
Dr. Moore.
Thanks. I think one analogy to use that might help people think about the individual decision-making with HPV vaccine in this age group is more like a travel vaccine. It's more like what we discussed earlier this morning with JE vaccine, where it's a little easier individual clinical decision-making than something like meningococcal disease or meningitis B, where an individual's behaviors are not related to risk in the same way. It's hard for them to assess if they're at higher risk than someone else because it's an invisible risk. But for this, it's much more like a travel vaccine where it's a little easier to assess. But I think the importance of having at least an individual clinical decision-making recommendation is coverage and access, and that the conversation should be held with women, because there are men and women for whom this vaccine is beneficial, and they would be put in an out-of-pocket situation to have to pay hundreds of dollars out of pocket for this kind of protection that's safe and effective if it really is important for them. So I think that decision should be left between them and their doctor, and they should have access to coverage for that.
Dr. Rockwell?
Hi, I need clarity here. Is this individual decision-making the new buzz for a B category recommendation?
Yes, so in February of 2018, when we adopted the evidence to recommendations framework, the 3 types of recommendations now are no recommendation, individual clinical decision-making recommendations, or routine recommendations.
Correct. And I told everybody I knew that after that meeting. And then I keep seeing level B recommendations mentioned again in people's talks. So I think, I just needed clarity. So if it's an individual decision-making, insurances still will cover, according to the ACA. Yes.
Any other comments? Dr. Baker?
I just have a silly question. So right now, it is true that the majority of the work group is favoring individual decision-making, but there is a minority that wants to make no recommendation. Correct, Dr. Markowitz?
That's correct.
In that context, in June, let me say it a different way. Given that, will there be any more data presented in June? Question 1. And question 2, that would influence this decision. And question 2, what's the current uptake of HPV vaccine, and what's the slope likely to be in the next couple of years?
Well, yeah, we presented the coverage at the October meeting, and I don't actually have a slide with me, but I believe the coverage was included in a slide that Dr. Brisson had, which is showing the coverage. And Melinda might know this off the top of her head, but I think at least one dose coverage is about 63% in females, 68% in females, and 63% in males. About that, but it has been increasing gradually every year in 13 to 17-year-olds, and it is, of course, that age group is aging into the 20s, and so coverage is gradually increasing.
And will we see any more data that might sway an opinion one way or another?
Well, one thing is that a lot of these health economic results that you saw today are really kind of hot off the press. Even like in the last week, we've been trying to finalize. So the work group needs to look at these again and really digest them and understand them. And I think we do want to have a better understanding, and also to bring the feedback from the ACIP members to the work group and decide. The other thing is the AIM survey, for example. We just got those results last week, and we haven't been able to completely synthesize those with the work group.
Any other comments or questions?
Sorry, one quick point of clarification. I just wanted to clarify the difference between we do not recommend and there is no recommendation in which we stay silent. And my assumption is we're talking about we do not recommend. Is that correct?
No, we're not, actually. No,
It
because
is
it's no recommendation. No one was thinking we do not recommend. It was
No recommendation,
It was
no
a
comment,
no
okay.
recommendation. So I think the choices that Dr. Cohn mentioned were no recommendation, a recommendation for individual decision making, and recommending for. But the fourth recommendation, in a sense, is just no recommendation. There was no recommendation, and that's, I believe, the recommendation that has been the situation for other vaccines as well. We would not be recommending against. There just would be no recommendation.
So if we're going to have a vote in June, I was just wondering what the options that might be, so that to see if there are things we might need to help making that decision. So will there be, instead of just to 45, would there be that option to do a catch-up to 30, increasing the age from 26 to 30? Would that be an option? Or would the option just be to increase the mid-level to 45? I mean, I saw some of the analysis here. So would those be some of the options we have to vote, or would it have to be either, categorically?
Right. Well, we did discuss some of these issues on harmonization, and we did focus on harmonization, I want to mention. But, for example, 26 versus 30. Some of the work group members felt, well, people are used to 26 already, and we should keep it at that. And there'd be a lot of other issues that would have to be addressed, like the electronic health records and the IIS and some other systems that would have to be changed if one was going to change the routine catch-up to age 30. So that was an example of one of the discussions we were having. Other people felt we should consider harmonization age 30 to acknowledge the extended age recommendation. However, if that was going to be based on the health economic modeling, we need to go back and really look at that. I feel like there's still a lot of different messages from the health economic modeling, and so that's not giving us a clear indication of whether or not we should increase the routine catch-up age to an intermediate level between age 26 and 30. And that's one of the challenging things. We don't have a clear guidance from the health economic models in terms of them giving a consistent message.
Dr. Freihofer.
Sandra Freihofer, American Medical Association. Dr. Markowitz, this is sort of a comment and a question regarding the no recommendation, which does not mean not recommended. Would that be similar to what the ACIP did when we made the transition from HPV-4 vaccination to HPV-9 vaccination for the revaccination of those adolescents and young people that have received the HPV-4 series? And as I recall, our guidance included explaining the incremental benefits for males and females. Is that what that would mean, most likely?
That was a little bit different because we did not actually bring that decision to ACIP. That was strictly CDC guidance. And so I see this as somewhat different because we're actually bringing this before ACIP, but it might be translated or might manifest it the same way in terms of what information we provided.
Any other comments from the the voting members or the liaisons? Okay. Very good. We'll take a five-minute break. 5-minute break. Thank you.